Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Dear colleagues and PGs, we are discussing abdominal tuberculosis as an ongoing saga. Yesterday we discussed the historical background of abdominal tuberculosis. Today we shall discuss the pathophysiology and diagnosis of abdominal tuberculosis. That what is the pathophysiological mechanisms? How does this abdominal tuberculosis happen? And how we can diagnose this disease? Then in tomorrow's lecture, we shall be discussing the different types of abdominal tuberculosis. As said in the intro, today we are going to discuss the pathophysiology and diagnosis of abdominal tuberculosis. Extrapulmonary tuberculosis occurs in about 20% of the tuberculous patients. Out of 100 patients, 20 patients, they have extrapulmonary tuberculosis. 80% have the pulmonary tuberculosis and 20% have extrapulmonary tuberculosis. Abdominal tuberculosis constitutes about 10% of the extrapulmonary tuberculosis. So out of 100 tuberculosis patients, 80 will be pulmonary tuberculosis and 20 will be extrapulmonary tuberculosis. While out of these 20, 90% are extra-abdominal and 10% are abdominal. The gastrointestinal involvement is found in 75% of abdominal cases, with the terminal ileum and the ileocecal region being the most common sites of involvement. I repeat, out of 100 cases, 80 cases will be pulmonary tuberculosis and 20 cases will be extrapulmonary tuberculosis. And when we see the extrapulmonary tuberculosis, 90% are extra-abdominal and 10% are abdominal. The extra-abdominal, these are the lymph nodes, these are the meninges, these are the bones, these are the other areas. Then in abdominal tuberculosis, 70% are GIT involvement and 30% are non-GIT involvement. And in the GIT involvement, the terminal ileum and ileocecal region being the most common sites of involvement. Approximately 15 to 25%, on average 20% of cases with abdominal tuberculosis have concomitant pulmonary tuberculosis. So if a patient has abdominal tuberculosis, there is 20% chance that the patient may have concomitant pulmonary tuberculosis as well. So these are the statistics. Abdominal tuberculosis is defined as Mycobacterium tuberculosis infection in the gastrointestinal tract, peritoneum, or intra-abdominal solid organs. It doesn't mean only abdominal, the GI organs. This is whatever is within the abdominal cavity. The GIT, the peritoneum, are the other abdominal organs like kidneys, adrenals. So all these will give the collective name of abdominal tuberculosis. Main routes of abdominal tuberculosis infection are by ingestion, ingestion of infected food or milk, and this will be called primary intestinal tuberculosis, as whatever food or milk the patient takes that infects the intestines, and this is called primary intestinal tuberculosis. Then the patient may ingest infected sputum from the pulmonary source, and this will be called secondary intestinal tuberculosis. So by ingestion of food or milk, which will be called primary intestinal tuberculosis, and by ingestion of infected sputum from the pulmonary focus, and this will be called secondary intestinal tuberculosis. Then hematogenous spread from distant tubercular focus. It may be pulmonary or it may be somewhere else. But the infection may reach abdominal cavity through hematogenous route. And that comes the contagious spread from infected adjacent foci. Like kidneys may get infected from the intestines, intestine may get infected from the kidneys. So this is the contagious spread from infected adjacent foci. And the last one is through lymphatic channel. So these are the four ways how the abdominal tuberculosis infection happens: by ingestion of infected food or milk or infected sputum, by hematogenous spread from the distant tubercular focus, contagious spread from infected adjacent foci, and through lymphatic channel. And this is the grammatic presentation of these: ingestion of non-pasteurized milk, ingestion of infected sputum, the hematogenous spread from primary lung, focus, miliary TB or other organs, distant spread from adjacent organs, direct spread from the adjacent organs, and lymphatic spread from infected lymph nodes. How to diagnose? Diagnosis of abdominal tuberculosis, by no means it's a dilemma. It's really a complicated process. For the diagnosis, different ways and means are being used: the hematological, ascitic fluid analysis, radiological studies, biopsy and histopathology, and molecular and immunological techniques. Now we shall discuss each and every component in some detail. Taking the hematological way of diagnosing abdominal tuberculosis, hematological findings are non-specific and include raised ESR, anemia, and hypoalbuminemia. All these are really non-specific. Coming to ascitic fluid examination, if it is present, the tubercular ascitic fluid has protein more than 3 grams per deciliter with a total cell count of 150 to 4000 and consists predominantly of lymphocytes. I repeat, protein more than 3 grams with WBC count from 150 to 4000 and predominantly lymphocytes. The ascitic fluid to blood glucose ratio is less than 0.96 and serum acetic albumin gradient SAG is less than 1.1. This is the another aspects of the ascitic fluid examination. That ascitic fluid to blood glucose ratio less than 0.96 and serum acetic albumin gradient less than 1.1. The yield of organisms on smear and culture is low. If you send this ascitic fluid for culture, the yield will be low. Staining for acid-fast bacilli is positive in less than 3% of cases, and a positive culture is seen in only 20% of cases. So, absence of bacilli on staining or absence of growth on culture will not exclude abdominal tuberculous ascites. Therefore, mostly we depend upon the protein levels, the WBC and lymphocytic count, the ascitic fluid to blood glucose ratio, and serum ascitic albumin gradient. More details about ascitic fluid. Ascitic fluid adenosine deaminase ADA levels are elevated in tubercular ascites. Serum ADA level above 54 units per liter and ascitic fluid ADA levels above 36 units per liter and an ascitic fluid to serum ADA ratio more than 0.98 are suggestive of tuberculosis. I repeat, ADA level more than serum ADA levels in serum more than 54 and in ascitic fluid more than 36, and the ratio of ascitic fluid to serum ADA more than 0.98 suggestive of tuberculosis. However, in cases of co-infection with HIV, ascitic ADA levels can be normal or low. Also, falsely high values can be seen in malignant ascites. So this is not the pathognomonic of tuberculous ascites, but it is helpful in determining whether the patient has got tuberculosis or not. Interferon gamma levels are also elevated in tubercular ascites. Then sensitivity and specificity of interferon gamma levels is increased by combining ascitic fluid levels and ascitic fluid levels of the ADA and interferon gamma acids. So when both are increased, it will suggest tuberculous nature of the ascites. So if I conclude, in tuberculous ascites, proteins level more than 2.5, most of the times more than 3 gram, SAG less than 1.1, TLC more than 500, predominantly lymphocytes, ADA more than 40, PCR for mycobacterium tuberculosis may be positive. Coming to the radiological studies, the third way of diagnosing abdominal tuberculosis. Various radiological studies are used for the diagnosis of abdominal tuberculosis, and these include ultrasound, plain X-ray abdomen, barium studies, CT, and MRI. Coming to the ultrasound, ultrasound is an initial modality of choice which is useful in picking up lymphadenopathy, tubercular ascites, peritoneal thickening, omental thickening, and bowel wall thickening in some cases. So the role of ultrasound in abdominal tuberculosis is that it can tell that there are lymph nodes, ascites is there, and you then aspirate that, do the diagnostic tape, and do the analysis. And I've discussed with you the analysis, that the reports of the ascitic fluid, which will be suggestive of being tuberculous. There may be peritoneal thickening on the ultrasound, or mental thickening, or bowel wall thickening. So a good sonologist can tell about all of these features. And we do come across when the ultrasound is suggestive that this ascites seems to be tuberculous, there is thick fluid, there are exudates, there is lymph nodes, there is peritoneal thickening, or there is bowel wall thickening. Coming to the another modality, the plain X-ray abdomen, the plain radiographs may show enteroliths or even perforation in case of tuberculosis, ileocecal or other areas tuberculous perforation, and features of intestinal obstruction. Like in this case, plain abdominal radiographs in supine and erect position showing dilated small bowel loops with air fluid levels in a patient who presented with subacute intestinal obstruction secondary to tubercular ileal stricture. So these are the dilated loops supine, and when this was erect, there are fluid levels. So the plain X-ray abdomen can tell you that if the patient has got enteroliths, perforation, or features of intestinal obstruction. Third modality is that of barium studies. These are still gold standard in diagnosing strictures, fistulae, erosions, etc. We shall discuss this in detail in the next lecture on the types of tuberculosis in abdominal tuberculosis. But remember that barium studies has got its role. The CT abdomen, contrast enhanced CT and CT enterography provide adequate cross-sectional imaging in depicting various forms of abdominal tuberculosis. And we will see these examples in the next lecture. What about biopsy and histopathology? If the ultrasound or CT scan tells you the lesion and you take the biopsy, the methods of biopsy include endoscopic GI mucosal biopsy. You did the colonoscopy and you find the lesion in the ileocecal area, and you took the biopsy, or lower down in the colonoscopy and you took the biopsy. You did the endoscopy and there was lesion in the small intestine or stomach and you took the biopsy. Then image-guided percutaneous biopsy, like that of lymph nodes or some other stricture or some other mass. Image-guided percutaneous biopsy. And then the EUS-guided biopsy, more specific, and surgical open or laparoscopic biopsy. So, tissue for biopsy may be taken through any of these ways, either endoscopically or image-guided percutaneous or EUS-guided biopsy, or surgical, which may be open or laparoscopic. The caseation necrosis in granulomas is the histologic hallmark of tuberculosis. We know that the hallmark is caseation necrosis. Intestinal tuberculosis, the granulomas in intestinal tuberculosis are multiple. They are larger, more than 200 micrometer, and coalescent in mucosa and submucosa. These are the features of tubercular granulomas. And this is what we see: multiple mucosal and submucosal epithelioid cells, granuloma with Langerhans cells in cases of colonic tuberculosis. So the typical picture is there in case of intestinal tuberculosis. What about molecular and immunologic techniques? The clinical samples can be ascitic fluid, lymph node, thickened omentum, or mesentery. So any specimen from any of these can be subjected for PCR examination. Multiplex PCR using MPB64 and IS6110 are useful in the rapid diagnosis of gastrointestinal tuberculosis. In confirmed cases, there is 90% 92% sensitivity and 100% specificity, and if these are confirmed by AFB, culture, or histopathology, so the PCR has got very high sensitivity and specificity. But if it is suspected, then the positive results are seen in 72% to 75%. So, the diagnosis of abdominal tuberculosis remains the dilemma even in today's modern era of medicine. And we use combination of these parameters, and these are hematological, these are ascitic fluid examination, these are radiological studies ranging from the ultrasound, plain X-ray abdomen, barium studies, CT scan and MRI, then the biopsy and histopathology of the subjected biopsy, and then the molecular and immunological techniques, the PCR studies. And with the combining results of these possible parameters, we make the diagnosis of abdominal tuberculosis. And in clinical practice, what happens that many times we give empirical therapy to treat the case as abdominal tuberculosis. And when the patient heals, when the patient improves, we make the diagnosis later on down the time that yes, this was a case of abdominal tuberculosis. So I end here. In the next lecture, we shall be discussing what are the types of abdominal tuberculosis. Till then, Khuda Hafiz, goodbye.